Okay. So you can tell me any particular system you want in medicine.
Since we decided on CNS, we can start with CNS, ma'am.
Yeah. So do you want me to just differentiate all the neurodegenerative disorders for you?
Yeah, anything that you think would be important for CMS.
Okay, so we can either go for a little bit heavy. That neurodegenerative is like 8 lesions to be differentiated against each other. Okay,
Okay.
so and if you take neurodemyelinating conditions, it's multiple sclerosis and GBS. Okay, I might have marrow on me, but it's very difficult for me to open it in a mobile. So for now, I will open this.
No worries, ma'am.
And if you said you already have previous question papers, but if you want to have the previous question papers, I have it on me as well. So you can let me know about that.
Yes, ma'am, I would actually because I've been giving the exam last 2, 3 years. So I purchased the book before that. So I don't have the last 2, 3 years explanation, and also it'll be helpful if you could share. I'll message you on
Okay,
Telegram
okay,
for that.
okay. That's perfect. And do you have them as PDFs or do you have them as like a
It's
book with
a
you?
hard copy. Yeah, it's a book.
Okay, you have it as a book. Okay, that's good. So one second, let me open neurodegenerated. So here you will only have like basic information that you want to know, okay, regarding your differentiation concepts. So today,
Yes.
majorly, we are going to try to differentiate Alzheimer's, Parkinson's, and vascular dementia, and Lewy body dementia. Okay, so let's
Okay.
differentiate these four because these four things are very similar to each other. Okay, so
Yes.
if you take Alzheimer's versus Parkinson's, okay, so what do you think is the first symptom that you will have in an Alzheimer's patient?
Rigidity, tremors, that
Yeah, that is
shuffling
Parkinson's.
sort of gait.
Yeah. Okay, so you already know about the tremors, the resting tremor, and the rigidity, and the patient coming with shuffling gait, micrographia.
Yes,
So all
yes,
that is Parkinson's. So
yes.
basically, all of them are extra potential. So just for a little bit knowledge, whether I'm being fast or not, you finished MBBS like, is it long back or recent?
Long back, ma'am. 2017 I completed.
Oh, that's not that long back. It's okay.
Uh,
So I was
like
expecting
I
like a
haven't
10 year.
been, yeah,
Yeah, yeah,
like I
yeah.
haven't been
So,
in connection with books after that since I got married. So after that, I just hardly read anything since 2017. So just been giving the exams,
okay,
but
okay, okay.
yeah.
But suppose if you think that no issues at all. But if you feel like I'm being fast anywhere in particular concept, you let me know. Okay?
Yes, sure, ma'am.
Because at the end of the day, we need to understand like where you're wrong or how is it right. So
Yes,
now
yes.
in Alzheimer's, it's usually memory loss. Okay, that's the first symptom. Okay. So why am I saying Alzheimer's is causing a memory loss? For that, we need to understand where the degeneration is. Where is the degenerative lesion is? Okay, the degenerative lesion is basically in the hippocampus. Okay, so I
Okay,
want you to remember we have you do have pathology, okay, you do have physiology, you do have medicine, okay, but I will be discussing everything together
yes,
when I take one topic, okay. So
right.
now if you ask me like what's the anatomy behind the Alzheimer's disease, to know where is the Alzheimer's patient, which part of the brain is it affecting, okay, so it's going to be the hippocampus that they have given you already over here. If you want, you can. Okay, so you need to remember the
Right.
hippocampus. Okay, the next is what is the pathophysiology behind your both patho and physio behind your Alzheimer's. Okay, so Alzheimer's is basically like we have certain components A beta. Okay, so this A
Okay,
beta protein is what is getting accumulated. So that means we do have a way for that A beta protein to get out of the body. Yes, we do have. So we'll have like we have certain enzymes, gamma, alpha, beta. Okay, so these secretases enzymes are there. Okay, alpha
okay,
secretase, beta secretase, gamma secretase. Okay, but what happens is usually this will cleave that APP protein, amyloid precursor protein, which accumulation of which amyloid precursor protein, if it is there, you will have a familial onset of Alzheimer's. Okay, so if this is cut up, okay, it is going to be secreted. But this is not cut by your alpha or beta or gamma secretase, so you therefore have a beta, that is amyloid beta protein, that is being accumulated. If this A beta is accumulated, what is it forming? It's forming a neuritic plaque. Okay, it's forming a neuritic plaque. So
Okay.
that is why you need to remember the same A beta is what is causing your intraparenchymal hemorrhage, because it's causing an amyloid angiopathy. Okay,
Okay.
so now the second form or pathophysiology in an Alzheimer's patient is because, see, the plaque is same thing, that is extracellular. The deposit of the A beta and forming the plaque, it's extracellular. But the patients having this neurofibrillary tangles, which is hyperphosphorylated tau protein. So what is hyperphosphorylated tau protein? All these insoluble microtubule proteins are there, right? So these
Right.
insoluble microtubule proteins, they're going to be like tangled with each other. Okay, in the first concept, your E beta is actually the APP is being accumulated. In the second concept, the microtubule tau protein is not secreted out. Okay, it's a hyperphosphorylated tau protein. So it's forming
Okay.
tangles inside, and therefore you have neurofibrillary tangles. And the third problem in Alzheimer's is that you have a reduced cholinergic function. Okay, so because you have a reduced cholinergic function, the decreased ACH, the patients are going to be having cognitive abilities to be declined. Okay, this is pathophysiology. What are the three pathophysiological concepts contributing to Alzheimer's?
Uh,
Neuritic plaques,
mm.
fibrillary
Neuritic
tangles.
plaques, neurofibrillary tangles, and decrease in acetylcholine in the brain.
Yes, perfect. You're right. Okay, so now how do I differentiate an Alzheimer's and Parkinson's? In an Alzheimer's patient, I will first have memory loss. Okay, so memory loss is going to be first, let me differentiate that. It's not sudden memory loss, there will be insidious memory loss, like a very slow progression, insidious memory loss. So, what memory will be affected first? Your episodic memory will be affected first. Okay, your
Okay.
episodic memory will be affected first. So can they have your language impairment? They can have your language impairment. Okay. So first the naming will go, and then the comprehension will go, and then the fluency will go. I'm trying to say name, Wernicke center, and Broca center. Okay. So you should remember in that pattern.
Okay.
So the language center is gone. So the next is the temporal lobe. The next is your spatial disorientation, like where they are with the person, place, and time. Okay, that spatial orientation will also be gone. Okay, so this is what I mean by memory impairment. Okay, that is insidious onset, slow progression, memory, episodic memory being affected with a language impairment and temporal and spatial disorientation. Okay, so now after this, they can have neurocognitive symptoms. Neurocognitive symptoms is like all the mood disorders, because you will normally see an Alzheimer's patients coming with a depression, okay,
Mm.
and Alzheimer's patients coming with urinary incontinence, and Alzheimer's patients coming with very behavioral changes, like they can be very aggressive, very agitated, very irritable, okay, don't have any apathy. So the neurocognitive presentations, like certain skills and all, like dressing, maintaining their hygiene, all that, okay, you need to remember can be gone in a severe Alzheimer's disease. Okay, so this is
Okay.
the clinical features. Okay, so now what am I going to do is I'll finish the presentation of Alzheimer's and then I'll differentiate that with Parkinson's. Okay, so if you
Okay.
take like a diagnostic method for an Alzheimer, okay, diagnostic criteria is we need to remember they need to have a neurocognitive disorder. Okay, so that is basically nothing but you need to have an impairment in your learning, you need to have an impairment in your learning and in your memory. Okay, so you need to have an impairment in your learning and memory. So the cognitive declines should be very steady. Okay, so steady decline should be there. It should not be like, okay, they have a memory loss for like 2 days and then they get back to normal. Not like that. The cognitive decline
Okay.
is insidious, slow progressive, and it should be steady. Okay, and there should
Okay.
not be any other evidences for the reason for the memory loss. Okay, and they can have all these genetic and sporadic factors because the genetic factors are nothing but your APP, presenilin 1, presenilin 2, all these will cause, like usually if a 65-year-old is a common scenario for Alzheimer's, a genetic APP accumulation, presenilin 1 and 2 will cause a 50 years Alzheimer's, okay, Alzheimer's at 50 years, okay, but the sporadic ApoE2, ApoE4, when you compare, the ApoE4 has a more risk for your Alzheimer's than your ApoE2. Okay, so now that's why the diagnostic criteria is your learning and memory should be gone with a cognitive steady decline and no other evidences for it. So now I'm trying to do a MRI scan. That is the pathology again and radiology concept over here. When I do an MRI, I'm trying to see that there is a cerebral atrophy and I'm trying to see that because there is a loss of neural tissue, I'm having a little bit of enlarged ventricles. Okay, so you need to remember ventriculomegaly can also be there
Okay.
with your, because if the neural tissues are less, the CSF will appear to look more. So that is your hydrocephalus ex vacuo. Okay, so you can have maybe I'll show you that. Yeah. So you can see the picture over here, the C picture. If you
Yes.
comparatively see the neural tissue is becoming less, it's not the CSF that's becoming more. Okay. So that's why all these neurodegenerative Alzheimer's, frontotemporal dementia, Huntington's, they all said to have, apart from the Alzheimer's patient from a cerebral atrophy, the gyri becomes very narrow, neural tissue is lost. You can also have hydrocephalus ex vacuo. Okay, so when do we try to do additional studies is when you're not able to differentiate between the types of dementia. So that is a patient who's having Alzheimer's, Parkinson's, and all that. Okay, so let me come back. Yeah, we are here. So now let's concentrate on one more aspect. If you're trying to do a pathology like a microscopy, so you need to remember Hirano bodies is one of the feature that is a eosinophilic inclusion, which is seen in the hippocampus. Okay. So you have done with the pathology. The microscopic part is bodies, stop protein, and A beta accumulation. We are done with that. So now let's talk about the pharmacological management of Alzheimer's. So what are the three drugs that we basically give? So one, the whole problem is acetylcholine is low. So we try to increase that acetylcholine by giving them acetylcholinesterase inhibitors. Acetylcholinesterase inhibitors are nothing but rivastigmine or your galantamine or your donepezil. Okay, donepezil. So these are the three drugs we need to remember. Okay, rivastigmine, galantamine, or donepezil. All three of try to increase your acetylcholine, and therefore they can prevent the cognitive decline. Otherwise, if that is only for a mild to moderate amount of Alzheimer's, if you think the patient has gone to like a severe, a moderate to severe, you need to give them an NMDA receptor antagonist, which is memantine. Okay, so if you think that they have progressed even more, then you can also try to give like a monoclonal antibody. So that is your A beta monoclonal antibody, that is your aducanumab. Okay, so these are the options that we basically have. So the first option is acetylcholinesterase inhibitors to increase your acetylcholine. Second option is NMDA antagonist, which is memantine. Third option is your aducanumab. Okay, aducanumab. So actually the side effects of the drugs, I would like to keep like one class on it after every two systems or every one system so that we can
Okay.
differentiate the side effects together. Okay, so
Okay.
because we need to remember it like that.
Yes. Okay, sure.
Example, like cholinesterase inhibitors, they affect your SA node and AV node. So they will have a lot of risk of bradycardia, syncope, heart block, like that. Okay. So the next is in a case scenario of Parkinson's, it's usually your substantia nigra is what is affected. So substantia nigra is affected means usually you will have the extrapyramidal symptoms first more than your memory loss. So if you have extrapyramidal symptoms and if you have the memory loss or the cognitive decline for more than 1 year, then it is Parkinson's. Okay, if the time period between both of them is more than 1 year. But if you have the extrapyramidal symptoms and visual hallucinations, and if you have the memory loss or the cognitive presentation within 1 year, then it is Lewy body dementia. That's the only differentiation you need to know. Okay. So
Oh,
Parkinson's, yes, of course, this you know already. Resting tremor, pill rolling tremor, 5 to 5 hertz, rigidity, cogwheel or lead pipe, shuffling gait, bradykinesia, micrographia, and your postural instability affecting your substantia nigra. Okay, so these also have Lewy bodies. When you compare this with your Lewy body dementia, they also have Lewy bodies. Okay, but the only difference is within 1 year or more than 1 year, you need to remember that. And of course, the visual hallucinations and the REM sleep behavior disorder will try to differentiate it. Okay, so
okay.
now I told you differentiate vascular dementia also along with this. So vascular dementia is a stepwise decline. Okay, so vascular dementia is a stepwise decline. So they will tell you like how progressive it has been, like a very, very stepwise. So apart from that, you need to look at the background of coronary artery disease or a previous stroke, or the patient has a TIA, or any case scenario which is related to your
Vascular.
ischemia, trauma, yeah, vascular part. Okay, so if you take a MRI in that, I want you to know that MRI in Parkinson's is normal, but
Yes.
MRI in vascular will show you an infarct. The MRI in your hippocampus can be affected, and cortical atrophy can be seen in your Alzheimer's. Okay, so that's how you differentiate. Okay, so
Okay.
now we are done with these four. So now let's differentiate the Parkinson's itself with the other Parkinson's. Okay, so before going to Parkinson's drugs, how do we differentiate atypical or Parkinson's plus syndrome from Parkinson's?
Sorry, ma'am, I missed it.
Oh, okay. If a Parkinsonism patient is coming, okay, and this case scenario is, I'm so sorry about this. Yeah, if you have Parkinsonism patient coming and you want to differentiate that from your atypical Parkinson's, okay, or you want to differentiate that from progressive supranuclear palsy. So how do we do that?
Any secondary
First,
cause of
atypical.
that, like
So
Parkinson's
why
is
do you think
idiopathic,
Parkinson's is idiopathic? Yes.
whereas the other atypical one could have some underlying cause of it.
Okay. Okay. So you're thinking that, okay, like for example, your MTTP is one of the toxic substance. It's actually, if you come across it, you can look about it. It's about methamphetamines. Okay. Methamphetamines, one of the toxic substances, MPTP. So that can actually cause your Parkinson's. And we also have a lot of drug-induced Parkinson's as well. Okay. But the atypical Parkinson's is like, usually a Parkinson's patient will first have extrapyramidal symptoms, which is motor symptoms. Okay. And then the Parkinson's patient could have the postural instability, like ANS presentation, autonomic nervous system problems, and then the patient could have non-motor. This is the progression of it. Okay. So motor means we just now saw all the motor presentation. Okay. So what is the ANS problem, autonomic nervous system dysfunction, what all presentations you can have in Parkinson's?
Tremors come under that, maybe.
The tremors come under motor only, the extrapyramidal symptoms. The postural
Emotional,
instability,
some depression or something.
yeah, that is going to come under non-motor. So if you take autonomic symptoms, okay, so autonomic symptoms are like orthostatic hypotension, you're having some urgency in the urine, your sexual function is impaired, okay, so general ANS features. So for example, what I'm trying to say is in the motor itself, the tremors are first, okay, then your bradykinesia rigidity, then your postural instability, okay, and then your gait problems, okay. So
Okay.
tremors, and then your rigidity and the patient's bradykinesia, then your gait and your postural instability. Okay, and then only non-motor. Non-motor is autonomic, like your BP is affected, your vasodilatation in your sexual function is affected. Okay, urinary urgency will be there. Okay, so that will be there. Then psychiatric presentations and your cognitive decline. Psychiatric presentations will be there. Okay, Parkinson's dementia will be there. Okay, that's how they progress. But in an atypical, instead of having the tremor first, they actually have your postural instability. They will have the depression. They will have the dementia first. Okay, so atypical is wrong order of Parkinson's. If you remember like that, it's easier.
Okay.
Okay, so now Parkinson's is a symmetric, asymmetric kind of presentation. Okay, so it's not like they need to have both sides equal amount of rigidity. It's not like that. They're asymmetric. But when you compare that with supranuclear palsy will also have postural instability first, but they will be symmetric. Okay, they will be symmetric. That's the differentiation. And supranuclear palsy will not have the tremor. Okay, supranuclear palsy is a patient who comes with postural instability with a symmetric presentation with no tremor, and the rigidity is more in the axial than your limbs. Okay, if you take your rigidity, we always see that for limbs. Okay, but for supranuclear palsy, it's more of the axial. Okay, so for
Okay.
supranuclear palsy, you have the postural instability first, coming with symmetrical presentation, no tremor, more rigidity in the axial region, and of course the name supranuclear palsy, that supranuclear gaze will be there. Okay, so they can also have a pseudobulbar palsy because in a Parkinson's you can have dysarthria, dysphonia, dysphagia, that is your 8th, ninth, 10th. Okay, don't worry, I will give you the notes for this, and even in the marrow it's given the differentiation of Parkinson's and all. So right now,
Okay.
I just try to differentiate it orally for you one so that you
Really.
can look back and you can read about it. Okay, so notes is not an issue. I
O-
have a Tableau column also to differentiate all of this. I can send it to you right away. Okay.
Okay.
So whenever you have the postural instability without a tremor, with more of axial rigidity and pseudobulbar palsy and supranuclear palsy, it's basically your supranuclear,
Funny.
progressive supranuclear palsy. So Parkinson's will not have anything in MRI. And MRI, if cortical atrophy is seen, it's Alzheimer's. If you see like a patient coming with stepwise decline and cortical infarct, okay, that is going to be vascular.
Vascular.
If MRI, yes, right. If MRI is showing hummingbird sign, then it is progressive supranuclear palsy. Okay, if they are showing hummingbird sign, it's progressive supranuclear palsy. So the next differentiation of Parkinson's and Alzheimer's is multiple system atrophy. Multiple system atrophy is also symmetric. Okay, they also come with autonomic dysfunction first. Okay, but they can have the tremor, they can or cannot have the tremor. Okay, but it's usually not there. Okay, so
Okay.
what is the similarity? They can also come with postural hypotension and ANS features first, but they are also symmetric. Okay, but they can have the tremors. Okay, and about the rigidity, so I want you to remember that they have the rigidity, but that's not like a very important feature for them. Okay, it's not like they should be having the rigidity in the case scenario. Okay,
Okay.
they actually have less prominent features of rigidity. Okay, so the tremors can be there. Rigidity is not specific that it should be there in the axial, or it should be not be. It's not specific that it should be there in your limbs. Okay, but we need to understand in a Parkinson's, the rigidity will not come with spasticity. Spasticity is different, increased tone. Rigidity is different.
Mm.
Okay, so it's not with the spasticity in Parkinson's, and same with progressive supranuclear palsy. But with multiple system atrophy, you have the spasticity and the rigidity. Okay, because the UMN involvement is spasticity, and a multiple system atrophy is basically the cortex. So they do have like a little bit of spasticity. Okay, so the next is I. The supranuclear palsy will have that supranuclear palsy, but that won't be there in the multiple system atrophy, and they can involve your ninth and 10th nerve. Okay, and in the MRI, they will have a hot cross bump. Okay, so again, I'm saying if you have a ANS feature with a symmetrical presentation with not much of a tremor, not much of a rigidity, but if it is there, it will be with spasticity. With your ninth, 10th involvement, nerve involvement, with your hot cross bump, it is multiple system atrophy. Same ANS, symmetrical, no tremor, axial rigidity, supranuclear palsy, pseudobulbar palsy, hummingbird is progressive supranuclear palsy. Okay, but instead,
Okay.
if you have extrapyramidal symptoms, asymmetric, and then postural hypotension, and then that is ANS features, and then all the 9, 10, 11, and then your psychiatric presentation, cognitive decline with normal MRI is Parkinson's. Okay, any doubts?
No. No, ma'am.
Okay,
It's
so this is how I basically wanted to differentiate. Yes.
yeah. Okay, ma'am.
Yeah. So actually, I wanted you to have an idea like how the classes will be. So that's why I actually wanted to make like an introduction class. Okay. So right now, how do you want to deal with the subjects? If we are like starting up in like a few days, we'll be having regular classes, right?
Yes.
So how much portion do you want me to complete in a month or in a week?
Um. like I would be there till July, ma'am. So if I can complete the portion maybe at least 1 or 2 months prior the exam, maybe by May or so. So and I have only like the last year subjects. I mean the third and fourth year subjects for CMS. So maybe I will have to complete one subject a month. Is that too
Yes,
much?
actually, no, it's not at all too much. So I can finish the portions in like by coming January itself. Okay, so you don't have to
Oh,
worry about that. So like
oh,
how I'm saying, because see, we are not learning paragraphs and paragraphs. I'm
yeah,
telling you the exact differentiation process you have
presentation.
to know, right?
Mm,
So if
yes,
you take pathology, yeah, if you take like a Robbins textbook, if you read the pathology, of course, if you read like that, it will take 1 month. So I
right.
keep it like this. I take a particular system. I want to finish the anat. So you don't have anat physio for the CMS, but what is important is the pathology is important because they ask you that in biopsy, they ask you that is in MRI, they ask you that as a histological lesion, right? Like for
Yes,
example, if I want to diagnose a particular condition of a meningitis or something, I need to know like what is the pathophysiology. So for
right,
that, we need to cover a little bit of first and second year basics, but
right.
including that also I'm saying. Okay,
Okay,
so
okay.
uh, I
So
think I would need more time for medicine, which will be around 10 weeks. Okay, when I
sure.
do medicine, I'll do pediatrics together only because I don't like, there's no point of me like learning interception in a different class in a different month and learning the differentials of the interception like Meckel's diverticulum, Hirschsprung, and all of that in 1 month, and learning only esophagus and stomach and colon cancer in 1 month. If you're finishing GI, finish it together so you can do the questions together. Okay, so
Okay, sounds
we
good.
will take 10 weeks for medicine and pediatrics, and 80% of surgery is only GI. Okay, 80% of surgery is only GI.
Right.
So apart from that, okay, whatever is because ortho is separate. Okay, ortho we need it. Okay, so apart from that, if you take surgery, it's only vascular surgery that you have to like little bit concentrate, and these normal basics, burns, okay, or a patient comes with normal cellular changes, all these soft tissues, the sarcomas, the skin disorders, okay, these kind of presentations, okay. So
Okay,
10 weeks for medicine and pediatrics together, I do it. So the GI, if the GI involves a surgery topic, or if anything involves a surgery topic like gastric cancer, I will finish it then and there. Okay, so I won't like keep it for a surgery month. Okay, I'll finish it then and
okay.
there.
All
So
right.
after this 10 weeks, I want to do obgyn. Okay, because I wouldn't be doing much of in detail obgyn in I wouldn't touch the reproductive block. Okay,
Okay,
so that's how. So in the 2.5 months, that is till December, this is what I want to finish: medicine, pediatrics, and obgyn. After that, community medicine I want to touch upon. Okay, surgery usually you will be finishing it parallelly. Okay, surgery is not that difficult. Which is difficult for you?
like I said, ma'am, everything is difficult for me in fourth year. All the fourth year subjects are tough for me because I haven't read anything much in fourth year.
Okay, no issues
SPM
at
is
all.
still sort of okay with me. ENT and eye opthal is also sort of okay, but fourth year subjects are my weaker part.
No issues at all. No issues at all. So see, that's why I'm saying I need medicine and pediatrics to be like done in like at least 10 weeks. I need for that.
Longer
Okay,
time.
because
Yeah.
it's very voluminous. Even if I take
Yes.
one system, it will take 1 week. So there are 10 systems. It will take 10 weeks.
Right.
And that's the reason I want to keep that. And then we will touch upon obgyn. Okay, so obgyn is like a separate, like I need to teach you that obs part of it. Okay, gynecology at least I can teach in like medicine, uh like it does come in the medicine part also. Okay, a little bit here and there, like functional hypothalamic amenorrhea. What is your Klinefelter-Stearns relation with your reproductive or the cancers? Okay, it comes in medicine here and there, but OBS is not like that. OBS is entirely we need to differentiate it. Okay,
Right.
so yeah, so we'll finish off neuro in a week. Okay, right now, uh, I can do like a class per week. 23rd and 24th is a holiday for you.
23rd.
That Vijayasmi and
I I would be available on 25th. and 26th, like if that's okay.
1 second, I'll look that up. What day is that? 25th, 26th.
Wednesday and Thursday.
Okay, done.
So
Mornings or evenings when you'll be available?
mornings maybe.
Okay, okay, then it works. Mornings means I can do like 11 a.m., 10 a.m. like that, or do you want early mornings like 5 a.m. like that,
Um, Maybe
6 a.m.?
25th we can do in the morning, maybe 5 or 6 in the morning. 26th we can do maybe 11 a.m. if that works.
Okay, okay, okay. So shall I just do one thing? Because right now my schedule that I have written for myself is not an updated timing. Okay.
Okay,
So I'll write out an updated timing. Of course, if there, let's keep it morning for the 25th, 26th that you said. Okay. If there
okay,
is any class that is like clashing on that day, I'll